Hi, everyone. Today's conversation on perimenopause and menopause is an important one because how we feel, both physically and mentally, dictates how we're able to respond and react to every other shift and transition that's happening in our lives. Think about it. I mean, from how we do our jobs to how we're able to care for our kids or other family members, as well as our broader relationships, not to mention our overall quality of life. It affects really everything. We've called this episode, or this midlife truth, "You're Not Crazy, It's Hormones," because that's what I've heard from so many women that I've interviewed over the past 2 years. In this episode, we're going to cover not only some important history and context that left generations, and I mean generations of women, including myself, to suffer in silence, but we're also going to educate you on what perimenopause and menopause really is and how we can better advocate for ourselves as women. Because guess what? You're not crazy. It's your hormones. Now, this is personal for me. Perimenopause crept up on me and sent me into a downward spiral, which took me 3+ years to dig myself out of. And I don't want anyone else to have to go through that. I was wildly unprepared and I felt completely alone. And I want to change that. All right, let's talk truth.
Look, as a doctor, I am always telling my patients to look for clean skincare products, but many of the additives in topical skincare actually irritate skin. Womeness is the leading women's wellness brand, modernizing aging through education, inspiration, and clean solutions formulated to meet the needs of our changing bodies. Their skincare formulas have no parabens, phthalates, and sulfates, absolutely no estrogen, phytoestrogen, or added hormones, and they're vegan and gluten-free. Their award-winning products like Overnight Magic Nighttime Repair Cream and the Works All-Over Toning Body Cream are gentle enough for everyday use and are loved by beauty editors and consumers. Created by women for women, Womeness offers clinically and doctor-tested supplements, sexual wellness, and skincare products that help you navigate through hot flashes, changing skin, vaginal dryness, sleepless nights, and more, empowering you to live your life fully and age well.
All right, I couldn't be more thrilled, more honored to introduce our next guest. I have listened to her, tracked her, watched her. I have her latest book, Grown Women Talk. So, welcome to the show, Dr. Sharon Malone. You have been a pioneer, a driver in this menopause space, really digging in, rolling up your sleeves, and super passionate, honestly, about making sure women everywhere understand the nuances of perimenopause and menopause. So thank you for being here. And we're going to go deep. We're going to dive right in. Why are you so driven about this particular topic? Why do you want all women to understand what's going on when it comes to perimenopause and menopause?
Well, first off, I want to say thank you for having me because, this is a topic about which I am very passionate and I talk a lot about. You know what? It's the topic of menopause and perimenopause is really not new to me. I mean, I had been in private practice for almost 30 years before I left to start a new phase of my life that I didn't even know I needed to, but I did. So the menopause conversation was very different for me when I was training because I am of the generation where we actually were taught about menopause. We were taught about not just the symptoms and how to treat it, but really we were hammering home a lot of the long term health benefits of hormone therapy. And I had been doing this and having this conversation for 10 years before, the Women's Health Initiative, the study that
Mm.
many of your listeners may or may not know about, that came out in 2002, which really changed the conversation about menopause. And so the reason why I've been so passionate about it is because had 10 years of experience coming into this. And I knew that what was being said wasn't exactly accurate. I think a lot of it was misinterpreted. And it's been, oh my God, just the ability to sort of walk that back, it's hard to do because, when something's in the New York Times or it's in the Washington Post and it's all over, news media, women tend to believe it. And that belief has been reinforced by an entire generation of doctors who have grown up in the era post Women's Health Initiative who have been telling patients things that are, at the very least, uninformed.
So I'm so curious because as a fellow physician, I'm in that generation that was no HRT, no, 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 no. So I don't know what it was like prior. When you were doing hormone replacement therapy for women before that study came out, that landmark study, what was the experience women were having? Was it relatively positive? Was it, what were you seeing before all of this sort of landed?
I started with the practice in 1992. And the practice had been in existence for over 30 years before I joined
Wow.
the
Mm.
practice. So when I tell you I've seen every generation of hormone therapy in women, because the day that I started, I had women who were 82 and I had women who were 18. So I knew what it looked like for women who were 82 years old and who'd been on hormones for 30 years. It wasn't a scary sight. Trust me, these women were good. They were happy. They were doing well. And so you take that experience forward. And then as we sort of learned things, I learned a lot about how to manage hormone therapy. So I never was fearful of it. We were all taught that this was something that was beneficial, not just in the short term, but in the long term for women's health. And it's amazing to me how one study, well, it was a big one, but one study turned the world upside down. So no, I was never fearful of hormones. And again, it's just a matter of training. And as I say, it's unfortunate, but we've had 22 years now of having the notion, the negative impressions of hormones really kind of get set in concrete. And when something's set in concrete, you really got to
It's
come in with a
so
sledgehammer.
So
hard.
I have to
Yes.
pause there. So I'm curious because I have had the pleasure of listening to you in panels across the country over the last few years, talking about how we ended up here, right? And what exactly happened. And I would love for our listeners to get a little bit of a history lesson of what happened that famous day when that study came out, and what was the reaction, because I think that is such an interesting backdrop to why this conversation is now beginning finally to take place.
So the Women's Health Initiative, which was commissioned in the 1990s by the first female director of NIH, Dr. Bernadine Healy, was really designed to prove, not just through observational data, but to prove that women who took hormone therapy would have a decreased risk of cardiovascular disease. That was what the study was about. It wasn't about, does it relieve hot flashes? Of course it does. Do women feel better on hormones? Yes, they do. All of the things that we now know that hormones treat for symptoms, that was not the point of the study. So when they created the study, they said, well, women don't really get heart disease until about 10 years after menopause. So really more in their 60s, not so much in your 50s. So the study, I think from its inception, included women who were much older. So the average age of women entering this study was 63, but you could be anywhere from 50 to 79 and still be in this study. And it doesn't take a rocket scientist to figure out, well, if you're going to do a study to prevent something, perhaps you should give it to women before they have it. So that the study population was in no way really indicative of who got prescribed hormones early on. We gave it to women at menopause when they were symptomatic. So the patients were too old, one. So they didn't see the benefit in the decrease in heart disease. But then that wasn't even the killer. I think the real killer was when the study reported that there was a slightly increased risk of breast cancer. Hotly debated, even at the time, but that sort of conversation really got drowned out because the amount of the increase in the risk of breast cancer was actually quite small. If you look at it, you say, well, okay, 26% sounds like a lot. But when you look at it in terms of absolute numbers, if you look at women who don't take hormones, about 30 per 10,000 women per year will be diagnosed with breast cancer. Women who took estrogen and progestin in that study, it went from 30 per 10,000 to 38 per 10,000. So an additional 8 per 10,000 or less than 1 in 1,000 additional cases a year diagnosed with breast cancer. But here's the part that never really got communicated, and that is there was no difference in the mortality. So if you got breast cancer, whether you were on hormones or you weren't on hormones, it's not as if you got a worse cancer or you were more likely to die of it. Quite the contrary. And so that was the beginning of the end. When you say breast cancer to women, and that's the good news and bad news because we have heightened awareness so much. That is our number one fear, not heart disease. And so that was the undoing. So, that Women's Health Initiative, when women say now, oh my goodness, my doctor tells me I can't take hormones because I'm at high risk for breast cancer or because my mother had breast cancer, know that that is really not factually based. Because the other piece of this story, and I think it's really important to know, is that there were two arms of this study, the Women's Health Initiative. There was the part where the women who had an intact uterus, so they had to take estrogen and progestin. Remember, I told you, you can't just take estrogen by itself if you have a uterus. But there were also women who had had hysterectomies. So if you had a hysterectomy, you don't have to take the progestin, right? Well, that arm of the study was allowed to continue for another 2 years, even after they had a hold the presses moment and stopped the first arm of the study. And guess what we have found subsequently in the women who took estrogen only? Not only do they have a 22% decrease in the incidence of breast cancer, but there's a 40% decrease in the risk of dying from breast cancer.
Mm,
Now,
interesting.
did anybody, did you hear anything about that?
No,
Of
no,
course
not
not,
at all. Yeah.
because I think that it came out 2 years later because the study was allowed to continue for another 2 years in that arm, and all of the negative findings stuck like glue. And here we are 22 years still trying to walk that back. So, I think that the biggest fear that women have about hormone therapy is really the fear of breast cancer. And if you can allay that fear and really explain to women why that is unfounded, then you're at least starting to make some headway there. But you see what happens in doctors' offices. See, we have two problems. One, doctors who, weren't trained in the pre-era and have come up in the era where they too think it causes breast cancer. But you've got doctors telling patients that they can't or shouldn't, which is problematic. In addition, so the patients, people didn't come to this on their own. They didn't just make it up. The New York Times told them, Good Morning America told them, everyone told them that there's this link between breast cancer and hormone therapy, and it is not. And the unfortunate side effect of all of that is that women have suffered needlessly for a generation.
That is the hook, right? That it was 2002, right, when this came out, the study, and, news headlines everywhere. And I mean, the radical response, I mean, wasn't it, and help me to understand it, wasn't it something like 75% of all RX, all prescriptions for hormones stopped? I mean, almost instantly. I mean,
I remember it like it was yesterday because, I'd been, having these conversations and telling about how this is good for your health, is good for your heart. And oh, by the way, you'll be able to sleep and feel better. And in one day, they had that press conference, and our phone lines were flooded with women who were horrified and said, oh my God, doctor, you told me this and you said it was but you're going to give me breast cancer. It went, to give you an idea of, before the Women's Health Initiative, about 38% of women took hormone therapy. After the Women's Health Initiative came out and all of this data came out, it plummeted to less than 5%. And there it has basically stood in the 5 to 6% range for these 22 years. Now, what happened to those other women? Were they still symptomatic? Absolutely. But they felt as if this was not a viable option for them to treat the symptoms that they had, and that's the bad news.
Yeah, I was
Yeah,
one of
Dr.
those.
Malone,
Yeah.
well, I mean, I've been there, with these women who have just suffered, right? Like they have turned into shadow versions of themselves, right? And they chalk it up to getting old. They're like, "Well, this is just the way I guess it has to be. I guess I'm just getting old. I can't think, I can't feel, I have no libido, I'm gaining weight." And it is just a criminal, it's my mom's generation, right? They did not do hormones, and you're seeing one disease after another. And when we look at labs in the exam room, you can track between 50 and 60, those cholesterol markers are going up, the A1Cs are going up, all of these metabolic markers are climbing. So, no surprise that heart disease is presenting itself when you hit 60 or so. So, I mean, I think the shame and sort of the feeling of disempowerment that's been spread across the last 22 years, like you're saying, we're still undoing it. But to this day, women are fearful of hormones. What would you say to those women that are saying, "I'm scared of hormones. My mom had breast cancer. My grandmother had breast cancer. My aunt had breast cancer." What would you say to those women who are listening today?
You know what I think would be very helpful for them to do? And for those who are inclined, there's an excellent book, Estrogen Matters by Dr. Avram Blooming. And he really sort of debunks, and this is an oncologist. This is a man who has, for 50 years been treating women with hormones, with breast cancer. And once you sort of see it laid out in black and white, and he really explains really fully about where the data went wrong, how a lot of the conclusions that were made were really even then were problematic. And here's the thing: people uh, were really arguing about this in academic circles since 2002. It's not like we just discovered this. No, it has been a conversation, but it never broke through. So I would say this to any woman who is considering whether or not to take hormones and not choosing them because of family history. I understand that. I have two sisters who've had breast cancer. Breast cancer is rife throughout my family. But here's the story. I had two sisters who had breast cancer who were not on hormone therapy. The biggest risk factor that any woman has for developing breast cancer, and this is aside from the less than 2% who actually do have who are genetic carriers, but the average woman who is whether or not you're going to get breast cancer really depends upon a lot of things: lifestyle, diet,
Mhm.
alcohol use,
Wait.
lack of exercise. Exactly. These things are far more important in whether or not you will develop breast cancer than whether or not you take hormones. And to give you an idea, that one of the figures that we came up with, and it's not original to me, but we're so fearful of hormones, but taking hormones is less of a risk factor for you developing breast cancer, less of a risk than drinking 2 glasses of wine a day, than
Wow,
not
that's a great one.
exercising, than being overweight.
Say that again.
Far
Say that again.
I love that. I'm going to steal that. That's a good one. That is
true.
a great one.
So,
So,
so
it requires some perspective, but no one's
Yeah.
saying, "Oh my god." Well, then now they are. Do you see the study that came out recently that said that alcohol is now they're considering labeling alcohol at like 10 major cancers increase with the use of alcohol. So, it's a matter of what you focus on. And we focus on that because it gives us some degree of thinking that maybe if I don't do this, then I'm decreasing my risk. And what I'm here to say is probably not on the breast cancer front. Your risk is your risk. So whether you take hormones, you not take hormones, I can't tell you whether anyone will get breast cancer. It's common, and it's more common as we age. But what I can say and say definitively to women is like there are more things that you should be concerned about in your health as you age. There are more things that you should consider other than breast cancer: osteoporosis, cardiovascular disease, type 2 diabetes, all of which we know are decreased in women who take hormone therapy. So there's the positive argument for this has really not been sufficiently made. And I think that's my job. But that's the health stuff. But let's just bring it home to the day to day. How about you feel better? You can sleep. You're more productive. You're able to, if you are not sleeping, that in and of itself is a risk factor for cardiovascular disease. It's a risk factor for hypertension. It's a risk factor for developing type 2 diabetes. So, you can't take one thing out of the equation and act like, then I fix that problem. No, it is always going to be lifestyle, hormones, but you're not doing yourself any good or you don't get a medal at the end because you've suffered for 10, 12, 15 years because you did not do hormones. You may still get breast cancer. As a matter of fact, more women get breast cancer off hormones than on it, and all the other benefits. And I honestly believe that if we can make this argument forcefully enough and clearly enough, I think women will get it. It's just that they haven't heard it.
No, they haven't. And this is such a great opportunity for them to really hear that message loud and clear from you for sure.
So I have a question about, first of all, there's this whole discussion around, our aversion, the risk aversion, right? That women are more, risk averse to taking hormones when we're giving other medicine like statins out like candy, right? And so that's problematic unto itself, especially, if we are experiencing symptoms through menopause and as we head in towards the transition into menopause. But I'm wondering if you can talk a little bit about, well, what if you're not that symptomatic, right? What is the benefit to hormones if you're not that symptomatic? So, I recently, over my journey over the last 2 years it's been pounded into my head that we think of our ovaries as, a reproductive organ, and that is what they are there for. But in fact, it is really the central command center for our entire bodies, And so I wonder if you could just talk a little bit about hormone treatment as it relates to maybe non symptomatic people.
Right. But here's the thing. More women are symptomatic that think they're asymptomatic. Because again, menopause is way more than a hot flash. So if you are entering this phase of life and you have more frequent urinary tract infections, if sex is painful for you, if your hair is thinning, if your skin is dry, um, if you've got brain fog, if you've got joint pain, these are things that we don't associate typically with menopause, but they are menopause. They are lack of estrogen symptoms. So when we get to these things, we tend to treat. Well, like, oh, well, I'll go see a dermatologist because I've got dry, itchy skin. I'll see. Oh, I have anxiety and depression or irritability, so I will go see a psychiatrist and I'll get on an SSRI or an antidepressant for that. So I say that to say the more women are aware that of the fact that menopause is way more than a hot flash, then they will become it's like, oh, well, maybe this is something that can be treated with hormones. How about just the notion that if you have a family history or you yourself or a small person and you're at risk for osteoporosis. Well, whether you've had a hot, 100 hot flashes or no hot flashes, hormone therapy is one of the few medications that can be given preventatively for osteoporosis. So you see what I mean? There's more things, and I think that for women, and particularly when it comes to things like vaginal dryness, painful sex, loss of libido, that stuff, 80% of women will experience those symptoms. And the reason why you don't necessarily link them and you think that it's just more due to aging than lack of estrogen is because those symptoms for a lot of women come later. They may come 5, 6, 7, 8 years after menopause when your hot flashes are all gone and you think that you're all good. But if you are, here's another thing that people don't think about how the lack of estrogen changes your body composition. So most women will tend to gain weight as they get older because that's maybe an aging thing. But it also, even if you don't gain a pound, you are losing muscle and gaining fat. And if I had a dime for every woman who said, "Oh my God, what am I doing? Why am I gaining weight around the middle?" Well, that's lack of estrogen. There is at least, and I always like to say, I like to lead with the things that I know and then sort of, lean into the things that we think, you know. And I think it's pretty pure, it's pretty convincing evidence on the cardiovascular front that, women who take hormones have a 30 to 50% decrease in the risk of cardiovascular
That's
disease.
huge.
Yes, it's huge. It is exactly what we thought it was before we did the Women's Health Initiative, because timing matters. You can't prevent heart disease in a 79-year-old, but you certainly could prevent heart disease if you started the medication in a 50-year-old. That matters.
So I know you're a big advocate and you've been involved in a lot of legislation, right? There's a Menopause Research and Equity Act. When, or maybe it's happening and I'm not aware, like when are clinicians like myself and others, like when will there be like a clear set of guidelines, right? Like we have our preventive health screenings, right? At 50, everybody now it's 45, you need a colonoscopy, you need a bone scan, you need a, check of your heart, all these other things. When will it be automatic that if you are 45 to 50, your hormones are checked and screened, you are evaluated, in terms of like, hey, do you need to go on HRT at this point from a preventive standpoint, and tying it into the lipid conversation and the metabolic conversation, do you see that as the future through some of the work that you've been involved with? And maybe tell us a little bit about that too for our viewers and listeners who are not aware.
I think that we're inching towards that, because there are new guidelines in 2022 that, got updated. And I think the last ones were in 2017. By then, the North American Menopause Society, now it's the Menopause Society, that really talks about some of the things that we talked about the heart disease and the osteoporosis and all the things that hormone therapy is good for. It is also gives a very good explanation of the fact that estrogen affects every organ system in our body. It is not just a reproductive hormone. So, there are long-term consequences of having estrogen or not having estrogen. So yes, so we're doing better on that. But I have to tell you, a lot of the investigators who were um, part of the Women's Health Initiative are still alive.
Oh.
And and
Oh.
they're still holding tightly, because you don't wanna say, "I did the most expensive study ever, and we spent $1 billion and we got it wrong." Okay, so the last piece of it, I think that is really they're holding on to is the breast cancer thing, and remember I told you that's the scariest thing for most women, and it's difficult for them to let him go, but we're getting there, and I think one of the more pernicious effects of the Women's Health Initiative was not just, the fact that women threw their hormones away, and that was terrible enough, but it actually stopped research,
Hmm.
not just in the United
Agreed.
States, around the world.
Mm.
Wow.
So all of the things that we still have questions about, like, why don't we definitively have an answer about what happens? Why do women have twice the risk of Alzheimer's disease as men? Maybe hormone related. And there is at least research now that Dr. Lisa Mosconi is doing at Weill Cornell, who actually is saying, you know what? Yeah, hey, women's brains are different than men's brains. Oh, who knew? But she's got evidence of that because she's done brain scans of women premenopausally, in perimenopause, postmenopausally, and it shows clearly that our brains are reorganized by the presence or absence of estrogen. And is that one of the reasons? It could possibly be. And that's why I said the research thing. And there's a huge gap in the amount of money that's been dedicated
Yes,
to.
tell us that 10% fact.
Yes.
Yeah.
So I talk about a couple of things because in my book, I really focus on what I call the little a advocacy. And that is, what is you as an individual person who's going in to talk to a doctor? How do I advocate for myself? How do I not let someone who doesn't really know what they're talking about talk me out of something? I want to at least give you that set of, I'm like, here are the questions to ask, and here's some answers, and here's some resources. Don't take my word for it. I don't think this isn't a belief system. This is about science. So there's that. But there's also the other part of my work, which I call the big A advocacy. And that is where, why are we still asking the same questions that we were asking in 1992, and we're no closer to an answer? And that is just the research gap. And I think that once women get activated around that, the reason why we haven't advocated for ourselves collectively is because I think many of us didn't know. And to be quite honest with you, I didn't know. I had no idea until I started doing the research. I was like, "Oh my goodness, look at this. $45 billion the NIH, funds, and less than 11% of that goes to conditions that primarily or exclusively affect women." And when you get to menopause and things in midlife, oh, it falls way to the bottom of the list. So it's not even 10%, it's probably less than 1% of the research goes to that. So there's a huge opportunity that I like to say there's an opportunity um, for us to do better and to start really doing some of the work that we need to do to answer the questions. But understand this. This is the political piece of it. And if you're a researcher, you're not going to continually submit, proposal after proposal only to get rejected. You're going to do the research that gets funded. And it's not in women's health. That's the problem.
Let's be honest, midlife comes with some seriously unexpected changes to your sex life, like loss of libido and, yep, you guessed it, vaginal dryness. I know, it's a lot. But you're not alone, and thanks to Women-S, the leading women's wellness brand, you can tap into all their education, inspiration, and clean products that are exactly what your changing body needs. So let's talk about what we do need. Vibrators, for one. And good news, Women-S teamed up with Love Honey to create a powerful rechargeable vibrator that has like 7 vibration modes and a removable silicone sleeve. And who knew there's skincare for down there too? Women-S has 2 different vaginal moisturizers. I know because I've tried them. So check it out at womens.com/midlife and get 20% off all orders of $50 or more by using the code MIDLIFE20. That's MIDLIFE20 at checkout. Women-S, live fully, age well. I was just going to chime in that, I've always been astounded by that fact that something like less than 10% of NIH funding goes to women. Also astounded by the fact that, yes, to your point, like even less of that is spent on menopause when something like 75 million women are affected, from a perimenopause perspective and onward. So it's astounding. It's astounding, that, women weren't included in research since 1993, it started, women became, finally mandated to be a part of research. Yes, we are not little men. There's so many just really convoluted and disturbing data points about how we've ended up here. But that all being said, I wanted to switch gears a little bit because there's so much that we want to cover. And one of the things that I have, gone through and really seen in the women that I have spoken to in conjunction with the Midlife Truth Project is that, that women do feel very often like they are going crazy as they enter into perimenopause, and they don't know why. Right. And because they really don't, in part, know what in fact is going on. And so this episode we dedicated to the midlife truth of calling you're not crazy, it's hormones. So what I gleaned from these interviews as well is that, yes, our, feeds and our news channels are filled with information about menopause, but there are so many women out there that don't have information, that don't know how to ask the questions. That's one of the reasons why I really appreciated your book as being kind of one part medical journal, one part storytelling, one part, what do I do now? So if we could just take a few minutes to kind of backtrack and say, give us your 101 on menopause, perimenopause, and menopause. Like, what happens, and how early does it happen, right? And how much of our life is actually spent postmenopausal? Like, draw us a little bit of a picture for all the people out there that may not be as knowledgeable.
Thing that I have to say about menopause is that many of us sort of think about, and I say think about menopause, and you think that that happens to old women, right? Oh, well, menopause, that's like, my grandma, or she's going to be 50 something when that happens. Well, what happens when you're 40 something and you're still youthful and vibrant and doing all the things and you're maybe still getting your period? The reality is this, and there's a good way to think about it. If you say that the average age of menopause just means just having had your last period confirmed by a year of no periods, the average age of that event happening is about 51. Perimenopause does not have as clear a marker. It starts as early, anywhere from 4 to 10 years before you've had that last menstrual period. So let's say, and there are women who are going to be menopausal at 45. Just because it's average at 51 doesn't mean that applies to you. So that means as early as your mid to late 30s, you're starting to have some of these symptoms that you think menopause is in the distant future. You don't realize that it is a transition. It is a phase. You don't go through menopause in a day. It takes years. And in that transition, which is just that chunk of time in your reproductive life, between your peak reproductive years, usually, from puberty until about your early to mid 30s, and before menopause. Now, that's a long swath of time there. And any time in there, you can, even while you're having regular periods, the things that we associate with menopause, such as mood swings, hot flashes, irritability, mood disturbances are a big issue in midlife. And that's why when you say, "Oh, no, you're not crazy," we have known, how there are things you know it, but you didn't really know you knew it? Now, for any woman who's ever had a menstrual cycle, you know that how you feel at any point in your cycle, if you're not on birth control pills, really is dependent upon where you are in your cycle. You feel different a week before your period than you do at ovulation. How, it is affecting your brain. We know that. Postpartum depression, which is also a time when there are huge hormonal fluctuations. You had lots of estrogen, you have a baby, and then now you don't. It affects our brains. So we kind of knew that, but we've never applied that concept to perimenopause, and the same things are happening. And in perimenopause, unlike menopause, where your estrogen levels are low and they stay low forever because you're not ovulating anymore, perimenopause is really a time of tumult. It is, your hormones are high today, low tomorrow. It is the erratic nature of the hormone production that is really causing a lot of the mood disturbances that we get. Women start complaining of brain fog during this time. It's like, wait a minute, what was I saying? Or what was I doing? And they do think they're going crazy. But the emotional component, the rage, the irritability, all that stuff, that can happen well in advance of when you've had your last period. So I think as long as women understand that, you have an explanation. Now, what to do about it really depends upon how bothered you are by it. And I think that, and I am never one to shy away from lifestyle that changes that you can implement in midlife. We all should, you know, exercise, diet, get a good night's sleep. But sometimes, even with all of that, you're still not where you need to be. And the answer to that is not always the go-to, which is what you get in midlife is, "Oh, well, here's an SSRI." And I'm sure Dr. Taz, you know this, that
Oh, yeah.
that SSRIs, when you're already having problems with your libido,
Shuts it
an
down.
SSRI is gonna make that worse, so you've gotta figure out that this is it is it is an entire it's a rubric, perimenopause, under which many things fall. and that we have to understand that you don't go pick the symptoms off one at a time. Occam's razor, the simplest explanation is usually the right one. If you're 45 years old and you're having any of those symptoms, you don't need an expensive blood test, you don't need saliva, you don't need a sonogram, you need treatment. And you need to get to someone who knows how to treat and understands that you don't need 6 different medications to treat one condition.
I loved your line in the book, Dr. Malone, and I just like my heart went a little thumpity thump because I haven't had that doctor. You said, if it bothers you, it bothers me. And
I love that.
I just felt like, gosh, that is where I hope we go in medicine, is where a doctors can actually say, if it bothers you, it bothers me. So let's talk about it. Anyway, so well done in that statement.
Here's my fear though, is that, and I talk about this in the beginning of the book, that we're in a very changed medical environment. And I had the luxury of being in one practice in one place for 30 years. So I actually watched young women go through high school,
Mhm.
college, have
I
their
love
children, and
that.
go through menopause, all in one fell swoop. But that's not going to be the experience of most women. That's why it's so important that you know and that you learn how to advocate for yourself. If you cannot find that person, and it's hard because remember I told you we've got 22 years of doctors that haven't been adequately trained in how to treat menopause. So what are you supposed to do? You go to a doctor, and you will go to a doctor sometimes and the doctor will say, "No, you can't have that. You have a family history of breast cancer." No. Well, that was really the impetus behind my joining Alloy Women's Health, is because you realize that we're in a different world now, and how we delivered care 100 years ago is not going to be how we're going to deliver care now. And yes, it's going to take telehealth. You've got to leverage the expertise of a few people that know what they're doing over thousands, not just over the 10 or 15 patients I'm going to see a day. That's why that's important, because I don't want any woman, because she lives in any particular zip code, and it's not even, just the people in rural Arkansas. I have seen this in New York City, where women have been not able to find doctors or not able to afford the doctors that know how to treat menopause, because that's also a problem. So, what we do and what I sort of set out to do with Alloy is to say we've got to democratize this process. We can't have it such that it's cost prohibitive, either, financially or even from a geographic point of view, that women, and we won't get into this, but this is what's happening to women's care generally. Where you live is going to determine what kind of care you get. And that's in a lot of aspects. And we have got to address that and figure out better ways to deliver care. So that's my goal.
So, Dr. Malone, I mean, I'm right there with you. I run practices and people that have means, right? A lot of our markets, our areas, and they have access to everyone, the best of the best. They've been to the best of the best. They've been to all the big name institutions, and they can't get answers. And they land, in my exam rooms, and we're told that, well, this is normal. You're
Yeah.
just getting old. This is a
Yeah.
part of aging. You're
Yep.
35, you're 40, 45, 50, whatever it is. And I think that's an incredible disservice. I cannot imagine, and I always think about this, I can't imagine, if these women are having this experience, what is the experience that women in rural America are having? Or what is the experience that the inner city women are having, or someone with a language barrier? And I thought this was an American story, but as my book, kind of got published in other markets too, it is a global story. That study has reverberated around the world. Doctors around the world are practicing the same way, where no to hormones, no to menopause care. This is what aging looks like, you know. So alloy is an option for those women, but what else can be done to get that message to women in those communities, that may not, have access to a partner, to resources, to all of this stuff? How do we reach, all these different groups of women in America and honestly around the world?
Well, see, this is where you're going to need legislation. You know, you're going to have someone decide that women's health is important. We need to have this is where, you really need NIH to step up. I say all the time, regardless, there are so many things that we know from a preventative health point of view. We know what the answers are. Why don't people know them? And we don't know them because no one's making this, clear to them. And I would say we need PSAs for women's health the way we needed anti-smoking campaign, the way we needed wear your seatbelt campaign. We needed so everyone knows, everybody's on notice. We need again, we get back to needing the research, but there's certain things and there's certain things that government is going to have to do. And the first thing that we have to realize is that women just need health care. They need health insurance. Number 1, where they can even have the possibility of seeing someone. And then we have to understand that how we deliver care inefficient, horrible. You can't decide that because I live in Alabama and there are 2 doctors for 50,000 people, that's okay. No, well, then, you know what? We can do it another way. We just have not been very we haven't been we haven't had a really great imagination. We haven't thought outside the box about care delivery.
I had to add because I was schooled a little bit recently from a good friend of mine who's an OBGYN where I live here in Connecticut. And, I was kind of riffing on, the doctors and, oh, they don't know anything and they're not educated and shame on them. And she was like, whoa, 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 whoa. She goes, I think it's important that patients also understand the system in which they are held
True.
accountable to and
True.
and what
Very true.
women can do to advocate for themselves in advance of their appointments. So for example, that their mandated time with patients, that is very limited. The number of clients and patients that they need to see, the churn that they go through is really, I mean, it's unbelievable, right? So I wonder if you can talk a little bit about, I know you mentioned this in your book, but how to come educated to these appointments and what you can do. And I heard actually a good tip, and this was actually from Heidi Flagg, Dr. Heidi Flagg, who I know you've met, Dr. Malone. And this was a tip that I just thought was so interesting. She said, when you go in for your annual, don't come with your 14 questions. Oh, I think I'm in menopause. What do I do? Blah, 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 blah. Book a wellness visit separate to your annual because they have so much to do in their annual. They don't have time if you're going to a doctor who takes insurance. So I just wonder if there's anything else you can add, Dr. Malone and Dr. Taz, to the conversation about how do women gain more agency over their health and questions and doctor's visits. Like what can they do? And I'd like to talk like you to mention telehealth there because it is changing the landscape.
I think that the first thing is to be prepared. Know what you're going in there for, you know? And if you're going in for an annual exam, just understand that's preventative maintenance. Yeah, might you get something in there? Yeah, perhaps you can get a question or two. But the reality is, in today's world, you're going to get 5 to 7 minutes of FaceTime. Your entire appointment is 15 minutes, and most of that time you're going to spend getting dressed and undressed. So, your doctor's coming in and they're just like, and I don't I've been there. So I understand this that there is doctors are no longer in control of their time and their practices. Not they're going to be measured and monitored by how many patients they can see a day, not necessarily by how good of a job you're doing. There's a standard. I mean, I'm not being that harsh, but you know what I mean? It's not, you are being judged on productivity. You're in it. Doctors now are employees. They're not business owners. And when I was in practice, it was, there's a certain pride that you have about, this and keeping your patients. But now when we're in a world where your insurance may change next week, you may change a job or change location, or your employer changes your insurance, then that changes the whole mix of the doctors that you can even choose from. That doesn't make for a real sort of productive way to start and maintain a relationship with your physician. So what you have to do is that you have to be laser focused. It's going to require you to do a little homework on the front end, know what you're coming in for. And I agree wholeheartedly with Dr. Flagg. You can't get everything in 5 to 7 minutes. Maybe you need to come back. Maybe you need to have, and that's where I think telehealth is so important, because the things that you might need to talk about aren't things that need a face-to-face visit. It's inefficient for everybody for you to take a half day off from work, drive to where you're going, pay to park, all that. Y- Perhaps can that be done in a telehealth environment? Of course it could, because it's the talking part of it that gets, I think, sort of short shrift in a doctor's appointment. Everybody's focused on doing, and menopause and perimenopause are conditions that really are about talking. Tell me how you feel. What's going on? What are the other things going on in your life? You're not going to get that in 5 to 7 minutes. But when I tell you that, if you know that's how it is, do a little homework on the front end, know what I'm coming in, write your questions down, because we all know when we get to doctor's appointments, sometimes we get flustered. And the main thing you came in for, you forgot. And then there's the brain fog piece of it. We're like, oh, I meant to ask her. So it just requires, a checklist. What am I doing? I didn't get to your doc. And this is something that I think is vitally important. Whenever a doctor either tells you to do something or gives you a medication or whatever it is, make sure you know what it is and what you are taking it for. Doctor, what are we treating? Oh, you said go get a CT. What are you thinking? Because we all have in our minds what we are ruling in or out. And I think that that's the way that we get really a partnership, because I'm enlisting you in your care. It's just not me telling you what to do. We're in this. We're on team Julie. Okay, so what are we going to do? And then I think that those are the kinds of things that we're going to have to take a little bit more ownership. And I think that doctors and patients relationships in the past have been more passive. You know, I'm just going to do what the doctor says, or the doctor said this or whatever. And we've got to realize we have I think it's an opportunity. It's not necessarily, we don't have to look at it as a negative, but it's an opportunity for you to take a little bit more charge of your health and your health care, and certainly as you age.
I'll piggyback on that. Dr. Malone, like, I feel like I've gone rogue a little bit when it comes to medicine, because we really do run a model outside of the insurance system, and we have a whole team with different paying levels and all that other stuff. But the reason for that is our visits are about 45 minutes to an hour long. And we take that holistic approach. Now, I challenge myself with, how do we make this bigger, right? Not make it niche, right? I feel very burdened, responsible, whatever the word is for that. And I do think telehealth is part of the answer, but the other part of the answer are these books. I mean, I feel like these books that you've written, that I've written, that others have written, are almost like your companion advocate for you to be prepared no matter who that practitioner or provider is for you. Because while we run a collaborative model in our practice, I also have physician friends and colleagues, and I know the stress and burden, to your point, that they're under. Like, you can barely, get, how are you? Okay, let's check this. Okay, we're out the door, because it's all about RVUs and production. And so until we change medicine, which I feel like we need to do, and I'm very passionate about that, I feel like the resources from experts like yourself, that is a way to begin to advocate for yourself, because you can start to build that team. And I think it's having a team, and that team may be your, practitioner that's in network. It may be a telehealth provider. It may be a consult person, but you are really having now, unfortunately, to build that team until we get back to that model of medicine where you had a home and you had a quarterback, and that quarterback would be well equipped to help you navigate all the nuances of healthcare. So I feel like, a lot of the work that we're doing is an attempt to give women agency, no matter where they are, no matter what their socioeconomic status is, and help them to be able to move forward with that.
And when you get to this point in life, we have to deal with perimenopause and menopause. We're dealing with a lot of things. We're dealing with sexism, we're dealing with ageism. I think that we in the medical profession generally, we have we've become comfortable with women suffering. It's like, oh yeah, well, that's kind of what women do. They have cramps, they have migraines, they have PMS, they have this, and you think of perimenopause and menopause as just the latest in that continuum of suffering that women have gone through their entire lives. And if that's the expectation, and to say, oh well, yeah, what do you expect? It's perimenopause, you'll get over it. If that's the attitude, then we're not going to really change things. And I think that what I really, really, really want to do is I want to do a couple of things. I want women to understand that as we age, I want you to look forward to that time of life. Yeah, there's a
Yes.
lot
Yes,
going
yes,
on.
yes.
Hallelujah.
But there's a lot about this. If you knew the things to do ahead of time, and how do I keep myself healthy mentally and physically? How do I stay engaged? This could be the best time of your life. We're going to spend anywhere from 30 to 50% of our lives in our menopausal years. And you know what? And I think that one of the things that has been so good about the conversation of late is that we've sort of changed the face of menopause, you know? So whatever you thought menopause looked like, that's not what it is. And to be able to have role models and to see women who are out there who are active and engaged and doing things and pivoting and starting other careers later in life, that's the role. That's what we're trying to do. We're not trying to say, oh, well, poor you, go sit down and wait till you break your hip, you know? No.
I call it the journey up. We're
Yeah.
headed up, like
When we think about this kind of democratization of menopause and inviting other stakeholders to the party, to the conversation, whether that be employers, HR professionals, policymakers, the broader medical community. So not just our doctors, but our therapists and, couples therapists and whatnot, but also the big one, our partners, right? If you are married, if you are married to a husband or you are married to a wife or you have a significant other, how do we include them in a conversation? Because there's so much on the woman, and there is still, like it or leave it, there is still somewhat of a degree of shame, or a taboo around it, particularly in relationships. So do you have any advice or thoughts about where that conversation is going to go, or how to get over that?
Yes, I think that as we get more comfortable talking about it amongst ourselves, that we don't take that shame and stigma on like this is something we have to hide from the people in our lives. I think it's a conversation that you have with your children, because usually it's happening around the time when you've either got middle school or high school children. So it's high stress all around. But you can explain to them, you know what? Mom's a little on edge now. Know that, all the things that we know, explain to your partner, explain to your children. And my husband, it was funny when my husband read my book and he said to me, he said, oh my God, I had no idea. I'm like, where
no.
have you been? He's like, women have a lot. And I'm like, yeah, they do. But it is encouraging people to be able to speak openly about it without shame, without stigma, just to say it's what it is. Just like think about where we have come in the conversation about breast cancer. We're able to say that out loud as if, yeah, someone's had breast cancer. That was a shameful thing. It wasn't until Betty Ford where someone would even acknowledge, oh my God, I have breast cancer. I don't, it's not my fault. I'm not embarrassed. I can deal with this and move on. And that's sort of how we've got to deal with perimenopause and menopause. Have the conversation, explain, but you have to understand it yourself first. So you can then explain it to the people around you. And, the more we normalize these conversations and the more we know that we don't have to just endure, we really want women to thrive at this point in their lives. So anything that's getting in the way of you being your best, most productive self, eh, that's where you've got to access. You've got to access care, a spiritual advisor, your doctor, whatever it is,
The
because
team, build the team.
I build the team because I'm here to tell you, this can be I'm happier now at 65. There's no question. I'm happier at 65 than I was at 45.
Love it.
Promise.
What a promising
Oh,
message.
absolutely.
So, if you can, in like 30 seconds or a minute or five, whatever time you have, what is your midlife truth? Like, what is one thing that has been true to you?
My midlife truth took me a while to come to. And my midlife truth is this. It is not your it is not your responsibility to solve everybody else's problems. Not your children, not your husbands, not your friends. At some point I think that we take on way more than we should. And sometimes it's okay to say, "Oh, well, that's just too bad. Oh, I hope you figure that out." You know? And that's what I tell mothers to their kids now, and I can say this because my kids are grown, and I didn't do it, so I hope you do. You just kinda go, "Oh, that's terrible. They'll figure it out." So, relieving yourself of that responsibility for everyone, for your parents, for your children, for your spouses, for everybody, let it go and do the best you can, because if you focus on making you the best person that you can be, then it gives you a little bit more bandwidth to help everybody else. But otherwise,
Love it.
let it go.
It's perfect.
Beautiful. So beautiful. What an honor to have you on our show. Incredible.
Yeah, thank you. Thank you for giving back. Thank you for, being such a badass, if I can say that, and a staunch advocate for female health overall. We are going to include in the show notes, of course, everything about where they can find Alloy Health and where to find more information about you and your book. Is there anything else you wanted to add or?
Yeah, the one thing I really wanted to talk about was about the health disparity issue. Um, as we talked about, there's ageism, there's sexism, there's racism. There is how Black women and women of color sort of show up and the kinds of things that they have access to, even when you control for socioeconomic status. We have got to get rid of some of the misconceptions that we have about how we treat Black women. Because to give you an example, when it comes to menopause, what we do know from the study of women across the nation is that they followed women from premenopause through menopause. And what they have found is the following: that Black women tend to enter menopause earlier, their symptoms are more severe, and they last longer. That's just observational, is what it is. However, they are least likely to be prescribed hormone therapy or to even have a discussion about it, and are less likely to take the prescription even when given. So you're talking about a fraction of Black women who are treated. And these are the women who are suffering the most, and they get the least of the conversation, the least of the therapy, and then suffer ill effects for many years thereafter. And that's the piece of it that I think that conversation needs to be had, because there's the notion that certainly I was taught in medical school that Black women don't have this, they don't have this. Yes, they do. And we've got to really change that conversation and to make sure that all women, women of color, Native American women, Hispanic women, Black women are getting the message from a messenger that they trust.
Love it.
Thank you. Thank you for adding that.
Very important.
Well, thank you for being here. Thank you. Continue to enjoy where you are and what you're doing. You're doing such great work. And as a woman, I'm so thankful you're on our side.
You are so welcome. And you know what? This is also the advantage of being old, is like, you know what? I can just say whatever I want to say. And I'm like, I'm not in private practice anymore. And as I do say this because I mean it, and I said, you have to be really careful out here in the menopause world, because what the marketplace has really awakened to is the fact that menopausal women have money to spend. And so there's a lot of stuff. and you got to be careful. And you've got to, again, do a little bit of homework and make sure that, is this person that's telling me this, are they qualified to give me this information? Yes or no? Um, and then you have to say, do the old common sense check. I say, if it sounds too good to be true, it's either not that good or it's not true. So
I
figure
love
it out.
that.
But Dr. Malone, I have to add though, and you've said it in the book, I wouldn't say that you're getting older, you're increasing in value.
There we
That's what
go.
you
we
said.
go.
I believe
Yes.
it.
That's true. That's true.
I love
All
it.
right. Thank you for the time.
It was a pleasure.
Hey, good to see you.
Oh my goodness. Good seeing you.
It feels like 2 seconds ago, but I know we interviewed Dr. Malone yesterday, but I just wanted to recap with you. My head's been kind of spinning and buzzing. I mean, perimenopause and menopause is such an important topic. So I was curious about what you thought, what you took away.
I don't know. I just, first of all, how impressive, right? She's had such a long career in medicine, and to really understand sort of what she's seen and what she's been through, that's been sitting with me, because we never get to hear the stories of sort of what the doctors, 30, 40 years were doing. So I felt like that really sat with me. I think just her mission is incredible, right? To really democratize this movement, really make sure women of color get access to this. So I think there's just so much. And I think on one hand, it's amazing that we have advocates like her. On the other hand, it's like, wow, we still have a lot of work to do.
100%. Thanks for joining us today, and we can't wait for the next Midlife Truth called Families Change with author, podcaster, and PBS host Kelly Corrigan. And just a quick reminder, if you're new to the series, we meant it when we described it as an audio journey, because each episode is thoughtfully meant to follow the next. For example, our conversation today about hormones, menopause, and taking control of how we feel physically and emotionally directly impacts how we handle what's going on at home with our children, our aging parents, as well as other family members that we care about. Changing family dynamics is a big one. So join us for this next heartfelt episode with one of my all-time favorites, Kelly Corrigan. See you soon.